Start video. I put the start video. மேல அவங்க இதை click பண்ணு. And then you can mute yourself.
Hey, John.
Yeah.
How you doing, man?
Good. How are you? Can anybody see my screen?
I can see your screen.
So you can see I just put up this PowerPoint?
Absolutely.
See your screen.
Okay.
Hi, John.
How you doing?
Good, thank you. How are you?
Good, pretty good.
Hey, John.
Okay, it's still, I got 728, so we'll still get, well, 729. So I'll still give everybody a few minutes to log in. Everybody can hear me okay? Any problems hearing me?
No, we can hear you. Thank you.
Okay.
Roger that.
All right, I got 7:30. So if everybody's ready to go, I'll start up. All right, let's see. Just minimize this so I can see the thing. Okay. All right. So today we're going to talk. It's going to be a little bit different. Hopefully, everybody can, either forward this information on. It's going to not be a traditional type of going over EMG type of webinar, but it's going to be going over more so how the results of the EMG and why we're doing this test in the first place, and how we can use the results to help dictate our practice. So hopefully this can help for those of you that are new, or for trying to get marketing, as to explain to your physicians, to your docs, and to your staff members why these patients should have these tests. These are some real life situations that can help to demonstrate what the test it can be useful for. I can advance my slide. It's not. There we go. Okay. Oh, okay. So there's the objectives. We're going to take a look at some case examples of patient presentation and physical assessment. Using that, we'll establish a differential diagnosis that could be multiple things. And then we'll explore how the results of the electrodiagnostic study can alter the course of treatment, and then use the test results to help differentiate similar pathologies, give further insight, and to, most importantly, establish prognosis, which I've said many times is one of the unique features about this test, that it can help to establish prognosis. So first patient. Patient number 1 was complaining of pain at the medial elbow of the dominant arm after physical activity. The patient had difficulty grasping objects associated with forearm pain. So the usual tenderness area in the medial forearm. They did have occasional tingling of the 4th and 5th digits. The physical assessment examination revealed moderate weakness, mild to moderate weakness of the wrist flexors, and mildly decreased wrist grip strength using a dynamometer. Sensation was intact. They did have tenderness to palpation over the flexor and pronator origins at the medial epicondyle. Tennell's test was negative, but the elbow flexion test for cubital tunnel syndrome was positive. So kind of conflicting results on the provocative testing. So based on this findings, it's kind of straightforward case. What does anybody have an ideas of, kind of self-explanatory, about what the possible scenarios could be, both neurologically and orthopedically?
Sorry, right here. Let's take a look what we got here.
I mean, like a cubital tunnel?
That's the one that's what we want to think of first, but what else could possibly be? What orthopedic type injury presents similar to cubital tunnel?
Tendonitis.
Yes, tendonitis of what?
Medial epicondyle.
Common flexor tendon.
Common flexor tendon. So golfer's elbow, medial epicondylitis, or golfer's elbow versus ulnar nerve compression. So what can we do? We can do, we do electrodiagnostic testing. So we did a nerve conduction EMG study. We did the nerve conduction EMG study, and scenario A, we found that the test was performed and all the results are normal. Now, like I said in my last webinar, a normal test result isn't unuseful. A normal test result, we're still trying to figure out what possibly the patient could have. So a normal test result isn't a waste of time. It's kind of helping us to determine what's going on with the patient. So a normal test result would lead to a non-neuromuscular type injury, but instead a musculoskeletal type injury. So based on the normal electrodiagnostic study, we can now focus our treatment to the area in question, to the weak and to the weak flexor tendons of the forearm. So we can do our orthopedic type, and it's been a while since I've been in orthopedic practice, but I did it for quite a number of years. So some of these may not be completely up to date, but you want to stretch the passive extensors and strengthen the flexors, because those are what's going to be weak. Behavior modification is always important. Patient education, want to get them to use the mechanics of the forearm properly. Relieve repetitive stress on the flexors and pronators. Pain modalities can be helpful if the patient's in pain. So we can treat the patient as we would treat any other orthopedic type condition. Possible scenario. The other possible scenario is that the nerve conduction electrodiagnostic test is abnormal. If the electrodiagnostic test is abnormal, one of the more common findings would be ulnar motor velocity is slow or reduced across the elbow. And in more severe cases, it could be a block of conduction. A conduction block happens when we get reduced amplitude at the site of the compression and or proximal to it. So that could be a more severe type of nerve injury, myelin injury. In more severe injuries, worse than myelin, we could see axon damage. In axon damage, we may see reduced sensory amplitude in the dorsal cutaneous and the standard ulnar to the fifth digit, and you would likely see abnormal EMG findings in all the nerve innervating muscles distal to the epicondyle. So basically, everything from flexor digitorum profundus all the way down. So our treatment will be a little bit different. So our treatment, now that we've identified that it's a neuromuscular injury rather than a musculoskeletal injury, treatment would include nerve glides. Nerve glides, ulnar nerve glides are a common exercise for the, somebody's flashing me here. Let's see what's going on. Yeah, I don't know. Somebody's having some trouble. If you want to, if you're moving around a little bit, if you want to mute yourself for the time being, because it's kind of a little distracting. But if you have any questions, you can unmute yourself. So this way we can get going there. All right. So going back, we have ulnar nerve glides. Again, patient education. So patient education regarding avoiding compressing the nerve. So it's compression of the nerve. So you want to relieve the pressure on the nerve. And you don't want to stretch the nerve. So avoiding static elbow flexion is one of the more common causes of ulnar neuropathy at the elbow. Splinting is often of particular use in cubital tunnel syndrome. So splinting of the elbow or bracing about 45 flexion is the common position for all cubital tunnel splinting. And instead of pain relieving modalities, we want to relieve the pressure off the nerve. So we want to maybe focus on anti-inflammatory modalities. So cryotherapy or phonophoresis or pulsed ultrasound can be useful to help reduce inflammation and help reduce swelling around the nerve. So, if you choose to use modalities, in my entry-level DPT school, I teach modalities to the DPT students. I tell them not to overuse modalities. They are useful when used properly. So, don't disregard the use of modalities, but use them properly. So in this case, you would use anti-inflammatory modalities instead of pain-relieving modalities. So in summary, if the electrodiagnostic test was normal, that helps us because it's very sensitive. That helps us to rule out a neuropathy. We can also now incorporate musculoskeletal ultrasound. We can incorporate musculoskeletal ultrasound to help to check for damage of the tendon. So we can look for structural damage of the tendon. And our treatment, again, I went over it briefly, but our treatment will be based on an orthopedic type of intervention using the clinical practice guidelines and or recent evidence for golfer's elbow or medial epicondylitis. However, if the test is abnormal, if the electrodiagnostic test is abnormal, the test is very specific. So it's very sensitive to rule out, but it's also very specific to rule in. So we can still do musculoskeletal ultrasound for this patient, but now we can, and this is checking the tendon, because they may have both. They may have a musculoskeletal and neuromuscular. So we can also now scan the ulnar nerve. So we can take some cross-sectional area measurements of the ulnar nerve, look for the exact cause of the entrapment. If it's coming from the muscles or if it's coming from the tendon, we can look for that. So musculoskeletal ultrasounds can still be very helpful in this case. We use now different treatment techniques and interventions to focus on repairing the nerve. So we can focus on repairing the nerve, relieving pressure off the nerve to allow it to repair itself and reestablish proper biomechanics. So we do need to incorporate exercises, nerve glides to improve the functioning of the mobility of the nerve, but also proper movement habits to help to stop the future occurrences. And again, with electrodiagnostic, now that we have a positive study, we can help determine prognosis. So we can help establish prognosis based on the extent of the injury. A myelin injury, as always, is a better prognosis, while an axon injury, if identified with electrodiagnostic studies, is a poorer prognosis. So that's why the EDX test can help us there. So case number one was kind of straightforward as far as what's going on versus musculoskeletal versus neuromuscular. Case number two is actually a patient that I just saw yesterday. I just added this one into this discussion.
Hey, John?
Yes.
Real quick on case number one.
Sure, okay.
So, I treat a butt ton of these.
Mm-hmm.
That's Texas for a lot of these because we have a ton of golfers out here.
Right.
Definitely the therapists that do Graston or A-stem type of stuff works fantastically. Mm-hmm. And even if it's not a nerve problem, we still do neural glides.
Right.
And then also manipulation in the cervical spine and upper thoracic spine works out really well.
Mm-hmm. Right.
So all those would help out as well as far as either the nerve or the medial epicondylitis.
Right. Yeah, definitely. Yeah, like I said, my
I'm just throwing that in there.
Yeah, that's fine. That's perfectly fine. Like I said, my treating days are a little bit behind me, but I definitely know that I can find out where to find them. And you're definitely the Graston techniques. I've heard that's very successful. Nerve glides to help to promote mobility of the nerve. That's definitely helpful as well. But there is, just there is, and by far you have much more experience at the treatment, more recent experience. But it's just, just to show.
I understand that.
The little bit differences between how you would slightly different approach the management if it's a neuromuscular versus a musculoskeletal. So there's. Yeah,
and I wasn't trying to upstage or anything like that.
Oh, no, definitely not. No, I appreciate it. I know what I know what I'm out of practice in, and if you stuck me into a busy full day orthopedic schedule, I'd kind of be a little rusty. So I definitely appreciate any help. And definitely thanks a lot.
If it's a golfer, you have them go for some golf lessons, by the way.
Yeah. Mm-hmm.
And if it's a manual, it's a manual person does manual work. You work on their scapular muscles too. Right. Just throwing that out there.
Yeah, scapular stabilizers. I remember I treated a patient's lower shoulder dysfunction, and we always focused on scapular exercises first before you even touch the rotator cuff. So scap stabilizers are always very important with any type of working or manual work, things like that. So that's definitely important to add to the picture. Yes, definitely. Thank you.
John, also,
Yes, sure.
don't forget with our musculoskeletal ultrasounds to do a dynamic scan
Mhm.
of the ulnar nerve in the groove, and you can see on a dynamic scan if the ulnar nerve is subluxing out of the groove and where in the range of motion. So
Right.
you can sort of prevent that and make sure you're working them in a safe range.
Yeah, exactly. Yep. Yeah, that's what the one test, the electrodiagnostic tests can help correlate with other tests. In this case, if it is a neuromuscular problem, you can definitely use the musculoskeletal ultrasound to help add more information to the picture as far as the functional components of the movement. So you can do functional testing with the neuromuscular ultrasound. So you can definitely add more to the picture along those lines. Yes, definitely. I agree completely. Yes. Before we can go on, any other points from case number 1? Okay. All right. So I'll move on to case 2. And as I mentioned, this was a patient that I just saw yesterday. And it was a patient with a little bit older, 80-year-old man, complaining of a long history of localized back pain without trauma due to manual labor profession. He more recently developed burning and tingling of both feet. He had decreased range of motion of the spine, naturally for someone of that age. He had mild tenderness of the lower lumbar paraspinals with muscle guarding, abnormal orthopedic posture with decreased abdominal strength. Reflexes were mildly reduced, but nothing too abnormal for somebody of that age group in the distal extremities, but more normal proximally. Slight sensation decrease to light touch in the plantar areas of the feet, which is where he is complaining of the more recent symptoms now. Provocation tests, the straight leg raise test was borderline positive. The dural test was normal. So it wasn't really adding more to the picture, so that didn't really help me in that instance. His medical history was only significant for hypertension. He didn't have any of the other kind of red flags typical of patients with polyneuropathies, like no diabetes, no kidney or thyroid problems in his personal history. He did have a family history of diabetes, and because of his history of chronic back pain and some spinal abnormalities with physical exam, he was referred for the electrodiagnostic study by his primary care physician with a diagnosis of radiculopathy. So the differential diagnosis, when I started thinking in my head, was first off was lumbar nerve root injury. Tarsal tunnel was kind of in the back of my mind for a few minutes because the numbness and the abnormal sensation was localized to the plantar surface of the feet, so that was kind of in the ballpark. And maybe because of the family history, polyneuropathic injury was what I was thinking of. So scenario A, the nerve conduction study was abnormal. He had a prolonged H-reflex latency, and the EMG would be positive with spontaneous potentials in the lower lumbar paraspinal muscles and a few S1 innervated muscles in the lower legs. So this indicates that because he had spontaneous potentials, which means that the injury is new, there's active denervation going on, even though he had a chronic history of lumbar complaints, he has a new history of a new nerve root injury. So he has a new nerve root injury, so he would be referred for physical therapy to address his newly developing lumbar radiculopathy. Treatment could be focused at the low back area, again, modalities as needed for pain or for stabilization, for muscle strengthening, stretching and or stretching of the lumbar not only of the lumbar spine, but also the lower extremity muscles. Hamstrings can often cause a lot of tightness and pelvic misalignment, tight hamstring, tight hip flexors, strengthening of the lumbar spine, the pelvic, the core muscles, but also lower extremities. Lumbar spine joint mobilizations could be possible depending on the physical assessment and the intervertebral assessment. Postural correction and body mechanics. That's one possible scenario. The other possible scenario, which is what actually happened with this patient, the first scenario A was made up. Scenario B is this patient had normal distal latencies and velocities of the motor nerves, but the amplitudes of the motor nerves were all reduced. All the responses were very low amplitude. The sensory nerves were unobtainable, and the late responses were slow. So he had delayed of the atriflex, and he had delayed bilaterally, and he had delayed of the perineal F wave. The EMG for this patient, he had spontaneous potentials in only the distal muscles. So he had spontaneous potentials or kind of active denervation in the distal muscles, but we had abnormal motor units in the proximal muscles. So we had abnormal motor units in the proximal muscles, which the abnormal motor units indicates a more chronic injury. So he's got a more chronic injury at the same time as having a more newer injury. So the outcome was, or the impression was that he didn't really have signs of conclusive radiculopathy, but he had a polyneuropathy because all nerves were affected and in multiple areas in multiple limbs. So he had evidence of chronic and acute findings. So when I relayed in the report back to the physician these findings, so now it's the physician's, it was undetected before, so the physician's responsibility could be to do an appropriate medical workup. So the physician can do an appropriate medical workup running different types of tests. So one example could be fasting blood glucose for diabetes. Even though he didn't have it that he knew of, it could be, because it's in his history, that could be something to start checking out. Other possible findings, other lab tests, the creatinine and creatinine clearance could be used to measure for kidney disease. CBC and liver function could be helpful if it's an alcoholic neuropathy. I didn't get into that detail of history, but that could be a factor as well. Thyroid factor, the thyroid stimulating hormone, could be for hypothyroid hypothyroid problem. And he could also refer to, he could also have a nutritional deficiency. He can also have a nutritional deficiency. So you can check for thiamine, vitamin B12, methylmalonic serum levels. Could be a possible nutrition deficiency. Just give me 1 second. Hold on 1 second. So again, the patient management, the patient could still be referred to physical therapy to treat the low back issues, but again, it may not be the direct cause of his current peripheral symptoms. Interventions would be similar, but again, he needs management to start encouraging education about care for polyneuropathy, because develop, worsening skin conditions, which is often one of the biggest debilitating factors. Excuse me 1 more second. Sorry. He should be going into similar factors, having skin breakdown, things like that. So we can still address it, treat his musculoskeletal symptoms, but he needs medical management to address his the cause of his diabetic neuropathy. So this is where even both tests, both of them were positive, both results are possibly positive, but the management is going to be very different based on the findings that we encounter. So any questions on patient number 2, example number 2? So this is, again, both tests were abnormal, but the management is obviously very different. So any kind of questions or comments about patient scenario number 2?
So what's the conclusive diagnosis on the polyneuropathy?
Yeah, the patient had. I didn't get into detail about the electrodiag, but he definitely has a polyneuropathy. He has a polyneuropathy that's distal worse than proximal. It did have proximal involvement because we had abnormal motor units, and there was slowing in the late responses, so that indicates distal and proximal uniform findings. And so it was I forgot how I think when I termed it moderate, I forgot the exact number of the exact values of the findings, but it was a moderate polyneuropathy affecting the. I did test it. I didn't put it in there, but I did test an upper extremity, one motor and sensory nerve, and a couple of muscles. Those were normal, so it wasn't too severe, but it was affecting mostly the lower extremities. And so it was the bottom line diagnosis was it was a axonal polyneuropathy.
The cervical spine looks okay.
The spine, it is possible to rule in a spine problem in the presence of a polyneuropathy, but it's very tricky. The findings need to be worse in one particular area of the spine versus the other areas. So, for example, to rule in a radiculopathy, let's say at the S1 level, in the presence of a polyneuropathy, the S1 muscles would need to be more abnormal. So there'll be more diffuse findings in mostly the S1 muscles, while the other muscles would need to have can have positive findings, but not as bad. So it is possible to rule in a radiculopathy or anything else basically in the presence of a polyneuropathy, but that second finding has to be significantly worse than the other findings. And that wasn't the case in this patient. This patient's findings were kind of equal across the board, where they were all just about equally affected. So, he didn't have radiculopathy. He may have had some, spinal stenosis or things like that, but his main problem, which was likely causing his numbness in his feet, was the polyneuropathy and not the radiculopathy. Any other questions about case number 2? All right, so we'll go on.
I have one more question. Sorry, John.
Sure. Yes, go ahead.
Do you know whether he had an MRI done, whether it showed any spondylolisthesis or spinal stenosis? Or?
I'm sorry, I caught the end of it. I caught listhesis versus stenosis. I couldn't hear the rest of the question.
Oh, no, whether he had any MRI done prior to coming?
No, he did not have an MRI. No, he did not have any imaging studies done. This patient, in this example, didn't have any imaging studies done. No. He went to the primary. He told his primary he was getting, he had long back pain, but and he's getting some new numbness in his feet. So the first course of action was to refer him for the electrodiagnostic study. So he did not have imaging at this time. And at this point, imaging may help a little bit, but again, the primary cause of his his new primary concern is likely the polyneuropathy and not a spinal issue. So the more immediate more appropriate test to do at this time would be those laboratory studies to try to find out the cause of the polyneuropathy versus to look for any structural damage in the spine.
So if you were to do a repeat EMG, how long would you wait to do a repeat EMG or XEEG?
Well, with the axonal changes wouldn't be evident at least for 3 or 4 months after, because it takes a bit of time for the nerve to regenerate. So the earliest would be about 3 or 4 months, but it would have to be only indicative of either a worsening of conditions or basically just a worsening. Like if the management that he's going under was not helping, then that would be indicate to do a test again to see, if the neuropathy symptoms or neuropathy status is getting worse. But if he's getting better, then there really is no reason to do the test. Or if he's kind of maintained where he's kind of, he is 80 years old, so the otherwise generally good health, except for the polyneuropathy, but it lessens the chance of full nerve recovery. So, full recovery is probability is decreased because of the advanced age and the polyneuropathy status. So, but at the earliest that a test would even potentially show findings of axonal nature would be about 3 or 4 months. If it was demyelinating, maybe a little sooner. If it was primarily demyelinating, because the myelin can regenerate faster. But if it's an axonal injury, it's going to take 3 or 4 months for those changes to be evident.
Thank you.
You're welcome.
Hey, John.
Yes.
This is Dick Stewart here.
Hello.
Hey, if you were going to test S1 innervated muscles to rule out more of a neuropathy that would come from the radiculopathy,
Mm-hmm.
what muscles would you go after on that if you were suspicious of that?
Well, the testing an S1 muscle, the muscle itself doesn't tell you if it's no muscle itself tells you if it's a radiculopathy or if it's a polyneuropathy. It's the pattern of findings that you'd encounter. So, because you can have the gastroc is very easy and very reliable S1 muscle, but the gastroc could be abnormal in polyneuropathy, which it was in this case, or it could be abnormal in radiculopathy. So the muscle itself wouldn't, the one particular muscle itself or 1 or 2 muscles wouldn't tell you that it's spinal versus polyneuropathy. It's the pattern of findings. So for if I want to rule in a polyneuropathy, radiculopathy with S1, then it would be, you have more abnormal findings in, let's say, the gastroc and the glute max or the posterior tib or the peroneus longus. Those are mostly S1 muscles, but then the other muscles would need to kind of be mostly normal. So almost all the other muscles, like the anterior tibialis or the EHL or the vastus medialis or other muscles, those would need to be normal or very slightly abnormal to rule in that concomitant radiculopathy. So it's not so much one particular muscle that rules in or out, it's the pattern of overall findings that give you the overall impression.
Okay. So if you had some abnormal findings if you did all of those mostly or S1 innervated muscles,
Mm-hmm.
would you be more suspicious that it's a radiculopathy versus just only polyneuropathy?
Right. If the abnormal findings were worse in one area versus others, then you would have a little bit more evidence to rule in a second condition. The abnormal sensory responses, that right away shows that there's something else going on besides the spine. Because abnormal sensory responses, well, maybe in this case he is 80, so that could have been the cause as well. But in general, abnormal sensory responses are almost never caused by a spinal injury. Abnormal sensory responses are almost usually not caused by any type of spinal pathology. So that was the first clue, and I usually test those first anyway because they're more tolerable to the patient anyway. But abnormal sensory responses that I was getting, that started to lead me down the line of, okay, something else is going on here. And I went and I tested, then I kind of changed my plan as I went along. And then the consistent reduced amplitudes in all the nerves that I was testing, all the motor nerves, that kind of ruled in the polyneuropathy to help to rule in a radiculopathy. Again, I would have needed to see more findings in just S1 muscles or worse findings in S1 muscles or pick any versus others, but that wasn't the case in all his muscles were kind of equally affected. So that's how it ruled in. It didn't give me enough evidence to rule in a secondary radiculopathy.
Hey, John, one other question. Do you routinely get the workup of the appropriate lab test from the doctor?
Not routinely, no. In this case, I don't think the patient had any. This particular patient didn't have any before the test. He kind of just went in to the primary just for this low back issue. And then I'm hoping that, this physician I don't know too well, but other physicians that I would know well, I would recommend, hey, something else is going on here. You may want to, and I actually have an article that gives a good posting saying these are the lab tests to order for this type of condition. And I actually gave him an article. They gave this physician this article. So I said, here's the findings. Here, order these tests, and that's what he would do. Because I had a good relationship with this other doctor, not this doctor for this particular patient. But I said, okay, he's got demyelin. He's got an axonal neuropathy, worse distally. Here's some possible lab tests that'll help you determine the cause. And this particular patient, again, I don't have the relationship with this physician that I do with others, but but to answer your question, sometimes I do get the lab results. A lot of times I don't. That's where it's up to the managing physician in a case where something needs to be managed medically to order the proper tests.
Hey, John.
Yes.
Could you share that document you have with us on
that article? Yeah, sure. I can definitely post it. Yeah. Mm-hmm.
Man, we appreciate that.
Yeah, it's a little older article, but it's still pretty good because it definitely goes over appropriate lab tests to order for different types of neuropathy. So it has in one column the neuropathy, like the electrodiagnostic findings, like distal symmetrical axonal or proximal myelinating, and some of them have genetic tests to order, things like that. So I can definitely upload that article. Yeah, definitely I can do that.
Thank you.
No problem.
Hey, John.
Yeah.
So, did you do any of the anything beyond the tarsal tunnel?
I didn't actually get to tarsal tunnel because once I got no responses, I got nothing of the sural and perineal, superficial perineal. I got nothing on those, and the tibial.
I'm on my webinar.
The tibial motor amplitudes were so low to the abductor hallucis that I didn't, I didn't kind of explore that tarsal tunnel route because based on the findings I was getting from the easier sensory nerves, if you want to put it, I knew I wasn't going to have a good time trying to get those tarsal tunnel nerves. So again,
so would you have,
yes.
So would you have called that like the small nerve peripheral neuropathy, or?
Well, no, small nerve would be like just pain, or just proprioception neuropathy, temperature. Those are more small fiber neuropathies. The sensory to light touch, those are still, they're on the smaller side, but they're still kind of big. And he did have motor findings, so that motor nerves are larger. So yeah, small fiber neuropathy wouldn't. He's beyond that level right now.
So you wouldn't have gone into the foot to find out if there's some small nerve issues.
I'm just. Yeah, I did check an EMG foot muscle, and that was the muscle that did have those spontaneous potentials. The abductor hallucis and the EDB, those muscles were the ones that had the more acute findings. But to rule in tarsal tunnel in the case of a polyneuropathy is
what about the sensory nerves as well? I mean,
again, those the plantar sensory nerves, those are more challenging than the sural and superficial perineal. So if I didn't try it, but I would have probably hedged my bet that when I didn't get the sural and perineal, I wasn't going to get the plantar sensory orthodromically.
Right.
Because those are just really small and really hard.
I'm just trying to get clarification on how I would do my studies in the future. That's the only reason why I'm asking.
Yeah. Tarsal tunnel is hard to rule in when you have other findings because those nerve fibers are so much smaller. But he may have tarsal tunnel as well, but he definitely I kind of that's kind of looking through the what's that saying? Look through the forest from the trees kind of thing, where you see you may have the tarsal tunnel, but the polyneuropathy is definitely likely causing his symptoms as well. So he may have tarsal tunnel mildly, but the polyneuropathy is definitely is more concern at this point.
John, it's
Yes.
Vicki. Did you check an upper extremity?
Yes, I did. I checked the uppers, and those on this patient were normal.
Okay, so do you not have to have one upper extremity to call it a poly?
No, you have to test. You have to test the extremities, and depending on the source that you read, it may say you should have findings in 3 or more limbs, but in this particular case, you can still rule in because there's nothing else that it could be, because I definitely did test the upper extremities, and those were normal for his age. So just because they were normal didn't mean that I couldn't rule it in, because the findings were so blatant in this case. I didn't put in the exact numbers, but they were so obvious that that's the only thing that could possibly be caused. So there are different schools of thought and different arguments. You definitely need to test 3 extremities, but you don't always need to have findings, in 3 extremities to call it a polyneuropathy.
Okay, thank you.
Mm-hmm.
Hey, John, how often, this is Mark, how often would you say you see that, where you see it in just 2 extremities and not in a third?
I would say maybe about half the time, where you see you would see maybe about half the time that you'd see findings in, again, mostly the lowers. That's at least in my experience, that I've seen about half the time. where I see it more in the lowers than the uppers.
Right.
At the time I see it both uppers and lowers, but in the more mild the case, the more likely that it would just be the lowers. You know,
John, how long did you say he had been having?
The symptoms in the feet were only in, let me see if I can go back and find it here. Recent, so I think within like the last like month. So
Okay, so
within the last month
really.
that he started developing those new symptoms. So the last like month or so, that the new tingling and the burning in the feet, that was more of his issue. So and that's kind of where the going into the results. That's where the spontaneous potentials were evident, while the chronic potentials were more proximal.
Hey,
Thank
John.
you.
Yes.
Sir, when you find the lower extremity poly and you're looking for something in an upper, do you have a preferred pair of nerves you go to?
I usually do the ulnar sensory and the median motor. Those are ones I kind of, and median F. Those are ones I kind of go to first. Because the median sensory, if there's a chance of carpal tunnel, then that would, you know, that would be mildly positive. So I usually do ulnar sensory first, and then I go to the median motor only because the median motor is a little bit easier to get. But then if I see, then depends on the findings that I get. If the median motor is slow, then or abnormal, then I may add the ulnar motor and see what I usually start with the median, with the ulnar sensory, and then the median motor in F, and then I kind of add as needed as I go along. And that's what I did with this patient was the ulnar sensory, median motor in F, and those were all normal. So I kind of stopped, and then I did the EMG of the upper. I did deltoid, pronator teres, and FDI, and those were all normal as well. So that was the kind of end of my upper extremity adventures for this.
You do find the F necessary since you're looking at a poly?
Well, yes, that's where the F waves are helpful. The F waves are most, and the evidence shows the F waves are most helpful in polyneuropathies versus other conditions.
Yeah.
Because they're testing the entire segment of the nerve. So F waves are indicated in polyneuropathies to check for the entire status of the motor nerve. So F waves do have, they're not all that clinically useful, but their most clinical uses are in polyneuropathies.
Thank you.
All right, any other questions on case number 2? Okay, so we'll go to case 3. So case 3 is a little bit more cut and dry, but it's still a need for a test. The patient had a traumatic fracture of the proximal tib-fib with ORIF. He presented with foot drop and decreased sensation to light touch and deep pressure in the common peroneal nerve distribution. He had zero or trace muscle strength of the ankle dorsiflexors and everters and the toe extensor, so it's significantly weak. Obviously, it doesn't take a rocket scientist to figure out just from clinical exam that this was a peroneal nerve injury. The patient started PT and monitored progress. In this case, if there was no progress, 4 weeks after injury, which is the time frame to test for axonal damage, the nerve conduction study can be performed at about 4 weeks after initial onset of injury. So scenario number 1 is that the EMG was abnormal, but the findings showed slow velocities across the knee and only reduced amplitudes proximal to the knee. So the velocities were slow across the knee, and the amplitudes were reduced only at the knee and above. The EMG, there were no motor units in muscles that had 0 or trace. There were no motor units, but the resting potential, the resting assessment showed no abnormal insertion activity. So there were no fibs, there were no positive sharp waves, there were no increased insertion activity. So even though he's got no muscle strength, he's not able to recruit the muscle. The EMG was normal for spontaneous potentials. So even though he's got significant weakness, this is actually a good prognosis. It's a good prognosis because there's no axon injury. The lack of spontaneous potentials shows that this is purely a myelin injury, a severe conduction block across the fibular head or distal to the fibular head because of the swelling of the tib-fib fracture. So weight-bearing restrictions aside, you can treat the strengthening aggressively. You can go and work, the muscles are still innervated. They still have their full innervated capacity. So you can treat aggressively with NMES, with neurobiofeedback, aggressive strengthening as to his tolerance, with weight-bearing precautions, obviously. But you can treat aggressively because it's only a myelin injury, and as the swelling of the nerve decreases, as the bone heals, the strength will return pretty quickly. The other scenario is that the velocities were slow, but also now in this case, there were low amplitudes at all stimulation sites. The superficial sensory nerve had low responses, and now the EMG showed still can't recruit the muscles, but now there's significant spontaneous potentials. So there's positive sharp waves, there's fibrillations. So now we have signs of an axon injury as well as a myelin injury. So this is a more serious type of situation because now he has to regrow the axons. So he has to regrow the axons. So it's got to take time for that nerve to regrow. So he's going to need to have a brace. It's going to take a long time for those axons to regrow. And this was the scenario with this patient. This was a patient I tested a long time ago. But he needed, it was a younger guy, I think late 20s. He needed an AFO because he had significant foot drop after his tib-fib fracture. He lacerated the nerve in the course of the fracture. So he had damaged the axons of the fibular nerve or peroneal nerve. We kind of reduced the swelling, gave him an exercise program to try to recruit the muscles. DC E-stim can be better because DC E-stim is useful for denervated muscles. So instead of FES, which is primarily used for muscles that have an intact neural input, DC E-stim is better at getting just a brief, brisk contraction of the muscles, got no carryover, excuse me, but it's better at getting a more isolated contraction to get the blood pumping and get the movement going than FES, which uses, depending on the frequency, can either use alternating current or biphasic pulse current. Then once he starts to get more volitional potential, when he starts to show more strength returning on his own, then you can progress to the more aggressive phase. So, and that's what happened with this patient. I treated this is when I was still working in orthopedic practice, and we did the EMG, and it showed these findings. So for the first couple of weeks, first couple of months actually, I treated him like once a week. I treated him once a week, got him his AFO. We did some, swelling maneuvers. I showed him maybe exercise once a week. But, we couldn't do anything more functional based until about 2 or 3 months after the injury. So about 2 or 3 months after the injury, then he started getting some more dorsiflexion back. We started doing some more dynamic drills. By that time, he was weight bearing as tolerated from his orthopedic fracture. So it took him a much longer time to recover because of the axonal damage. So this is where, even though the injury was clear as day, it was a perineal nerve injury. The electrodiagnostic study showed us that the management was drastically different based on the specific findings that we encountered. So that's where the electrodiagnostic study helped us and was able to help us our prognosis and treatment plan. So any questions on this case?
I've got one.
Yeah.
John, I hadn't found E-stim very helpful in the past, and I want maybe that's just my experience.
You are just so funny.
Yeah, it's debatable how much it. There's a lot of evidence that is conflicting evidence. But the evidence that does
He knows what he's supposed to do.
That the DC
Kelly, we can hear you.
With the dog barking in the background.
Current is more helpful when DC current is more helpful when there's active denervation than alternating or pulse current.
Yes,
So that is evident in the literature that the DC current is more effective than alternating or pulse. How much effective it is, that's where the debate comes in. But how much effective FES? Well, FES actually does have the most evidence in neurologic type injuries, more so of upper motor neuron lesions. But there is a lot of evidence for FES for neurologic upper motor neuron injuries. So that's where FES. But it's not wrong to use it. But there's in orthopedic type of injuries like this, we wanted to get the DC E-stim in this case was more to just prevent atrophy than to improve strength. That's what the DC E-stim was used for in this case, was to prevent atrophy.
Oh, gotcha. Yeah, makes sense.
Any other questions or comments from case number 3?
Can I add something real quick?
Sure, ahead.
So, just real quick. I mean, hey guys, I love dogs and stuff like that, but it makes it really difficult to hear what's going on when everybody has their dogs and putting their dinner together and stuff.
Yes, agreed.
If we can put our mics on mute while you're petting your dogs and having your dinner, could that be done?
That would really help.
I've already sent an email. I think we need to be a little bit more etiquetely balanced, because I'm going to tell you right now, I've had a hard time hearing this whole thing with everybody's dogs and people putting their food in the microwave.
Yes, same.
And I hate to be a jerk about this, but y'all need to understand that I'm taking an hour and a half out of my life to listen to y'all play with your dogs and to put your food in the microwave and have your dinner. My phone's been on mute. My phone's been on mute the entire time, unless I have something to say. Can y'all do the same?
Certainly.
I would concur with that.
Try doing that, because I know everybody. I can already see everybody putting stuff down there, and I think it's important because I want to hear what John has to say. John's a freaking rocket scientist, and I'm having to hear everybody's world going on. Can we do that in the future?
Absolutely.
Yeah, definitely.
Thank you very much. I hate to be a prick about that, but somebody has to mention it. Okay.
Yeah, no, it's totally.
Yeah, I do. I do have the option of unmuting everybody, but then I kind of some of the parts of it are a little bit interactive, so that's why I do want to try to keep it.
You need to mute John. You need to mute people because they're not mature enough to unmute themselves or to mute themselves while they're having dinner and having their dog time.
Right. I apologize for the difficulties. I know it's.
I mean, I've missed about half of your discussion tonight.
Mm-hmm. I apologize for that.
You know.
All right. So we'll go on to case 4. So case 4. This is the most interesting case, this in my opinion. So we had 2 different patients with 2 similar types of presentations. So one was a 25-year-old male with a history of acute onset of low back pain, radiating to the right lower extremity after lifting a heavy box from the floor 6 weeks ago. He is no medical history, and he's a professional bodybuilder. The MRI was done, and it showed a small herniation at L5-S1 that was impinging on the right S1 nerve root. He had diminished sensation to light touch in the right lateral foot, 4+ strength in the right hip extensors, right knee flexors, and ankle plantar flexors, all S1 related, and +1 ankle reflex, so diminished reflexes. Patient number 2 was a 65-year-old male with chronic low back pain radiating to the leg for 2 years, so a little bit a lot longer history. He does have diabetes, and he's not a professional weightlifter, but he's a professional grandpa. He had multi-level findings of degenerative disc disease and degenerative joint disease with a bulge at L4-5 impinging on S1 and an even larger herniation at L5-S1 impinging on on the same S1. So he's got a double whammy hitting down for anatomically with S1. His sensation was absent, light touch in the right lateral foot, and he had even a little bit more weakness in strength in the same muscles, hip extensors, knee flexors, and ankle plantar flexors. And the reflexes were absent on the ankle. So based on clinical, from one more slide, and here's the MRI findings. So here's the MRI findings, and patient 4A is on the left and 4B is on the right, and you can see the circles got the L5-S1 space, and you can see the difference in bulge or herniation at the L5-S1 of the right versus the left, with the bulge on the right side of the screen at the L4-5 space impinging on the same root, on the same nerve. So he's got a much more significantly abnormal MRI results for the older patient on the right. So prognosis, if no electrodiagnostic studies, we would think that the younger patient has a much better prognosis. He's a big bodybuilder. He's going to come back. He's going to do everything really quickly. He has a little bit milder imaging study, so he's doing much better. Patient 4B, maybe time to take out the pasture. He's got significant weakness, significant abnormal findings, so it could be a much worse prognosis. This is without electrodiagnostic study. So we are good. So without electrodiagnostic study, the younger patient, we can start with our manual therapy, whichever school of thought you prescribe to, soft tissue mobilization, doing aggressive exercise with core strengthening, getting back to sport activities, and be a little bit more aggressive as far as treatment frequency with a shorter duration. With without the electrodiagnostic study for patient number 2, we would want to be more conservative with treatment. So maybe just modalities, to get him, passive treatment. He does have diabetes, so we do want to continue education. But basically, we're going to be doing very low-level exercises. So pelvic tilts, wall slides, bridges, would give to a patient in like a hospital setting. The duration would be much shorter duration, as far as not duration, shorter frequency, but a much longer duration, because we expect that the improvement is going to take much longer. However, we did do electrodiagnostic studies on these patients. We did do electrodiagnostic studies, and this patient 4A, the young guy, had a prolonged latency of the right tibial nerve at the ankle, and he had an absent right atriflex. The EMG was profoundly abnormal. He had severe, those of you that are not as far along on the EMG track, but he had severe findings in the S1 dermatome and the S1 myotome, glute max, bicep femoris, gastroc, low lumbar paraspinals. So he had severe acute denervation potentials present. Patient 4B, on the other hand, the entire test was normal except for a prolonged atriflex compared to the left. The EMG was totally normal. So patient 4A, what's the electrodiagnostic impression for patient 4A? What type of, they both have radiculopathies. What type of radiculopathy does patient 4A have?
S1.
S1.
Axonal damage.
They both have S1. They both do have S1. But 4A, somebody said it, axonal damage. They have diffuse, they have severe axonal damage.
It's severe acute, correct? I mean, if you're going to go by...
Yes, severe and acute. He has severe and acute axonal damage. Patient 4B also has S1 radiculopathy, but affecting only what? What's it only affecting?
Myelin.
Only affecting the myelin. So patient 4B only is affecting the myelin with no axonal changes. So they both have S1 radiculopathies, but the older gentleman has a much less positive finding than the younger guy. So patient 4A could be developing cases of man-colditis. And man-colditis is the most debilitating condition known to humankind, where he's going to be locked down for quite some time. While patient 4B, anybody know who that is in the picture?
Jack LaLanne.
That is Jack LaLanne. That is correct. Unfortunately, he passed away a couple of years ago, but he was still doing those tricep dips and way past his 90s. So definitely, the electrodiagnostic studies show that the prognosis for the older patient, we need to treat him like a young patient, because his intervention, we can be more aggressive than patient 4A, who's going to need a lot more TLC to improve those nerves and get those axons to regrow. So patient 4A, one thing that it was in there, but nobody picked up on it, was that he had, and I'll go back to the electrodiagnostic findings, they had a prolonged latency of the right tibial nerve at the ankle. So slowing of the nerve at the ankle, slowing identifies nerve compression. So he had a slow latency of the right tibial nerve at the ankle. So we identified, and here's the case where you have two things. We identified the radiculopathy, which was clear as day, but we also identified the slowing of the tibial nerve at the ankle. So going back to the treatment interventions, we need to not only address his lumbar issue, but we now need to address his tarsal tunnel syndrome. So we need to, orthotics are commonly prescribed for patients with tarsal tunnel syndrome, foot strengthening exercises, but a lot of times tarsal tunnel syndrome is often caused by pes planus or other types of foot morphology. So we need to evaluate this patient's feet and possibly, prescribe orthotics or get orthotics fitted to help address the tarsal tunnel syndrome as well. So the exercises are going to be much different. So the exercises, if you look at the slides, are almost reversed. So now for our young guy, we need to go slower. We need to do the more basic exercises, like the pelvic tilts, like the wall slides, bridges, ankle pumps, some basic core strengthening and stability to get the pressure off of that nerve. So even though the MRI results are diffusely different, the older gentleman, it's bulging and herniating, but not pressing on the nerve. In the smaller bulge on patient A, his nerves are being compressed, so we need to strengthen the core and get those nerves off, get those bulges, move them away, and support the spine. I threw traction in there. Again, traction is one of those debatable interventions where some evidence shows it's helpful, some not. So depending on your school of thought, traction could be helpful to temporarily relieve pressure off the nerve. But again, just like modalities, traction alone isn't going to do anything. You do need to strengthen the core and correct the any bony misalignments after the traction session. But traction can be used. And the treatment plan, again, it's going to be slower. It's going to be about once a week, maybe once to twice a week for about 4 to 6 weeks, and then increasing only when the symptoms are improving. So increasing the duration, the frequency, only when the symptoms start to improve. Patient 4B, we can still, if he has pain relief, we can, if we're limited in time, we can go to and use, give him a home TENS unit instead of instead of using our treatment time, spending on pain relief modalities, give him a home TENS unit, or, they sell them over the counter now, so you can get them over the counter and get him to manage his pain that way. And we can spend more time in therapy sessions on more corrective techniques. He still does have diabetes, so he has diabetes, but it's not affecting the nerves yet. We don't want it to affect the nerves, so we still need to educate him. We need to educate him on properly maintaining whatever he's doing for his diabetes is working. So educate him about, keeping up what he's doing. We can be more aggressive as far as the manual therapy and soft tissue as needed. But the exercises can be more aggressive. We can definitely do more aggressive exercises to work on improving those stability and getting those muscle strength restored to maximize his function. And the treatment plan can be more aggressive, increase frequency 3 or 4 times a week, 3 or 4 weeks, and the results should should be that the recovery should improve as as the exercises take into effect. So that just shows that another case where the physical exam findings may not give you a full picture, and the imaging studies, especially of the spine, may be misleading. Because here we show that the electrodiagnostic study is more indicative of the functional status of the nerve than the imaging study was to look at the picture of the bony or ligamentous or discus pathology. So any questions on the fourth case or questions on any of the cases overall?
I've got one.
Sure.
I think I understood you to say that because he had motor prolonged distal latency, that indicates there's a compression happening?
Yes, whoops, sorry, I lost my PowerPoint here. Let me go back to the last slide. Can you still see the screen?
Yes.
Yeah, so the prolonged latency of the tibial nerve at the ankle, anytime you see slowing identifies that there's a nerve problem. So he has slowing at the knee, at the ankle. So that rules in a problem at the ankle. So wherever we see slowing tells you that there is a problem. So because we had the slow latency of the tibial nerve, that shows us that we have a injury of the tibial nerve at that location.
Okay, yeah. When you said, I was just queuing in on the word compression, particularly, I guess.
Yeah, it's compression because the nerve became slow because of the compression. There was no slowing except for the atriflex. There was no other slowing. The atriflex actually was absent, so forget that. The atriflex was absent, but there's no other sign of slowing anywhere else where we would think that it's something diffuse slowing, like in the case of a demyelinating polyneuropathy. But wherever there's slowing of a nerve tells you that the nerve is injured at that location. And if it's only injured in one location, then it has to be compressed by either external forces or internal forces, whether it be swelling or external pressure or something that caused, or inflammation that caused pressure on that nerve at that location.
Okay, yeah, I'm clear. Thank you.
Mm-hmm.
Hey, John, can you just remind me, the atriflex is what evaluates the signal that's going through the spinal cord preganglionic, correct?
Well, it actually goes through the whole ganglion, so it goes through the whole pathway. So the atriflex goes through the entire pathway of the sensory nerve, stimulating the sensory nerve, going through the ganglion, then through the cord, then out the cord, through the motor nerve, back down to the muscle. So it's not necessarily preganglionic because it's the entire
whole thing.
The whole thing, yes.
Whole thing, but we're capturing that entire piece, so we know how involved that he's involved there at very close to the spine.
Right. Well, the reason why for patient B, the reason why we can say it's in the spine is because all the other studies were normal. So all the sensory studies were normal. So that shows that the sensory nerve was intact distal to the dorsal ganglion. We know
plus he had the opposite on. He had the comparison to the other side. He was lower. Mm-hmm.
Right. Mm-hmm.
Yeah.
Hey, John, I have a question on patient 4A. I know you said it was prolonged latency with right tibial nerve at the ankle, and not enough information maybe to give demyelination. It's obviously not axonal loss, and I know we're talking about like kind of, how we might treat it and stuff like that. But how would you classify that electrodiagnostically? Like when you go to your impression, would you mention it, or what would you say to that effect?
No, well, you definitely mention it because it's anytime there's an abnormal finding that's ruling in that's if you have slowing, that's ruling in that there's an injury there. So there's slowing is demyelination. So in this case, the person had two impressions. So he had the first impression that would be mentioned would be obviously the severe axonal radiculopathy of S1, but the secondary diagnosis or secondary impression is the tibial nerve injury at the ankle that is demyelinating. So he's got a double whammy, kind of double crush almost. He's got the radiculopathy at the S1, which is severe and axonal, but he's also got the acute, but then he's also got the demyelinating. I didn't put the exact number in there, but depending on how slow it was, it can be anywhere from mild to borderline to moderate slowing, which is an injury of the tibial nerve at the ankle. So he definitely has two conditions. So he has two problems we need to address. That's why we need to not only address his, lumbar spine, but also the ankle for, tarsal tunnel entrapment.
Thank you for that.
No problem. All right. Any other questions or comments, or kind of make a little bit? I spend a little bit more time on treatment than I usually do, but just to show you that just with one test can vastly, even when the results are the same as far as in case 4, or when the results are known before you even do the test, like patient 3, you knew he had a nerve injury, but the patient, the electrodiagnostic study, even when you know what the injury is, can be helpful to help you manage and influence your treatment care. So that's what I wanted to focus a little bit more on in this week's webinar, is how the test results can and should influence your treatment, which would help you to answer the question to your docs. Well, why do I have to have this test done? Or why should this patient have this test done? Well, this is the reason why. Because depending on what the test results will show, could vastly change the management of this patient, which is why you're doing the test in the first place.
Yeah, John,
Absolutely.
I think it's very, very, very helpful to do comparisons like this, and I think that's the value. Obviously, the value of EDX is that your treatment plan's more appropriate for the patient.
Mm-hmm.
And so
I'm wondering, yeah, go ahead.
And you can say to the doctor, this is how I would manage this patient based on this information. So I think it's extremely valuable. I appreciate you presenting it like that. So
cool. Thank you,
John.
So thank you.
You're welcome.
If you don't mind, I would like to jump in
the
conversation for a moment. First of all, let me say that it is so amazing to see so many people attending these webinars, and really awesome to see so many people are attending tonight. John, what a fantastic job you did. Let's begin with that. Linking electrodiagnostic findings, any type of diagnostic finding, with actual patient management, it is extremely important. Since its inception, HODS focused significantly on the diagnostic component and disseminating that diagnostic component and helping that diagnostic component to be learned well, creating competent individuals, competent professionals. However, we absolutely recognize the very significant need in order to create exactly what our intention is, a total transformation of the physical therapy profession, that we absolutely link diagnostic findings of all the diagnostic tests that we do with clinical treatment. I would like to show you guys something, and I will give you a couple of things of what is coming in the pipeline through HODS in this very issue. I will attempt to click share so you guys can see. Let me see. This will stop other screening sharing. Okay. John, I'm gonna just share my screen if you don't mind.
Sure, go ahead. Go ahead.
So, can you guys see my screen?
Yes.
All right.
Yep.
So, what I'm showing you guys here is one small element of how we will be able to disseminate to physicians how they can understand more on what type of patient they can compare to diagnostic testing and for what type of diagnostic testing. So this links patient's symptom with the appropriate type of diagnostic testing. But I'm going to take it a step further, and I'm going to show you something else. I'm going to show you medical patient management correlated with diagnostic testing results. This is something that shows what the condition, the diagnosis, the condition of the patient is, what is expected, generally speaking. Of course, there will be disclosures in these documents. Generally speaking, what the EMG nerve conduction test results are expected to be, what the ultrasounds are expected to be, what is the management that the physician has to dictate, and who the physician should choose to refer their patients to based on the condition. Now, what I'm showing you here is a very, very small sample of a whole campaign that will be starting after the upcoming September symposium. And I'm saying September symposium because we don't have all of the materials ready, and the materials we are hoping to include an actual book publication that will include specific techniques, physical therapy techniques, as well as medical management based on diagnostic results. At the same time, we are planning to spend the second day of the symposium in September, Sunday, the second day of the symposium, specifically on correlating diagnostic evaluations with actual treatments, and we will have practice labs of such treatments. Those will include specific manipulation techniques. It will include specific muscular inhibition techniques and neural mobilization techniques. So we'll help you guys get a further understanding and correlations to make for treatments more correlated and more applicable to diagnostic results. So that's
Dr. Christopoulos?
Yes, Mark.
Yes, I really like that that chart you just had there. I'm actually going to be speaking with some third-year PT students on some EMG testing. Would you mind if I use that?
I do not mind. I can send it to you. But I just want to say that it is not fully vetted.
Okay.
So, I mean, there are some disclosures here.
Don't worry about it. Yeah.
I'll give it to you. Just don't use it in an extremely wide fashion yet.
Okay.
Mark, don't use it as a handout, but use it as a slide.
Right. That's what that's what I was planning on doing, was just all I just wanted to do was just briefly show them like how PT can coincide with diagnostic testing.
Oh, definitely. Definitely.
All right. Thank you.
No problem. John?
Yes.
Back to you.
Okay, I lost the, I was done. If anybody has any other questions, I'll email everybody on the listserv, that article that shows the lab tests for referral, so I can email everybody that. But unless anybody else has any other questions, you can feel free to email me or whatever, and I'm glad to talk about it some more.
One last thing I would like to mention is, guys, make sure that you check your spam boxes, because we have programmed the system, I think 24 hours after each Wednesday webinar. Zoom is supposed to be sending you an email, which is a certification email that you attended the webinar. That is a proof email that you attended the webinar. Have you guys received that?
I have not.
We haven't. I haven't either.
Kevin?
I have not received that.
No, neither have I.
I don't think I have either.
Please check your spam folders. For that, check your spam folders tomorrow. Check for it tomorrow.
Is there any way to get the previous one that we have taken, Demi?
Yeah, I think last week was our first week doing it, yes?
Yes, and I want to show you. Hold on a second. I'll show you how it's supposed to look, okay? 1 second. Are you receiving a reminder?
We're getting reminders.
Yes, I'm getting the link. That's the reminder.
Yeah, I'm getting a link too.
So it's not spamming those.
Show you how this is supposed to look. You guys cannot see my screen yet, right?
Correct.
We cannot see your screen, no.
You can see my screen?
Nope.
Okay.
No.
Not yet.
Demi, I have a meeting I have to get to. Is it okay if I hop off?
Go to your meeting. I'm going to try.
Okay. All right. Thank you. Have a good night, everybody.
All right. So let me show you my screen.
Good night.
As you see, let me show you my screen. As you see, guys, this email is already in my promotions. It's not in my regular screen. It's under my promotions. And it comes from me, Dimitrios Kostopoulos, and it's a certificate of attendance, HODS weekly clinical meeting. And this is how it's supposed to look. Hi, it's going to state your name. Thank you for attending HODS weekly clinical meeting. We hope you enjoyed the event. And it says this email certifies that you attended this webinar and you may use your attendance towards your activity hours for EMG residency and MSK US fellowship. Make sure that you print this email and you keep it as proof of your attendance. This will count as 1.5 hours of activity time. This is approved by the HODS board. This is what you are supposed to be receiving. Please do me a favor and check your spam boxes tomorrow. Not spam, promotion. Look in the promotion box, right there. You see the promotion? It's right there, the promotion. Anyway, that's all for tonight. Thank you, John. Great job once again.
Thank you.
Hey, Demi.
Thank you, John.
Thank you.
Thank you, John.
You're welcome.
Thank you, John.
You're welcome.
Thanks,
Have a good
John.
night, everybody.
Hey, Demi.
Thanks, John.
You're welcome.
Demi.
Yeah, Jeff. Yes, Jeff.
Sir, can I get your slide too? I don't intend to share it with anybody, but I'd love to have it.
Send me an email.
Thank you, sir. Night all.
Bye.
Thank you, John. Thank you, Jimmy.
Good night.
Good night.
Thank you, Joan. Good night.
Night, John boy.
Good night.